see him. So welcome everybody. As you know, the format for this healthcare town hall is the first hour we'll hear from parents. They're going to share with us their healthcare issue or incident. I've asked that all the speakers try to keep to 3 minutes or less. Bear in mind that the shorter you are, the easier it is for people to remember what you said. I will be tracking 3 minutes, and I'll give you a wave or a little hands up on Zoom when we get to 15 seconds before the 3 minute mark. I'd also like to share with everybody that this session is being recorded and will be shared with the Disabilities Legislative Caucus. There is a group of wonderfully committed legislators in New Jersey who are committed to making changes to benefit our population. So we're going to start, and the first group up will be Janet Tavares, Sue Salic, and Kathy Tamburello. Oh, by the way, I'm sorry, let me just introduce everybody. Janet Tavares and Kyoko Koko from the New Jersey Council of Developmental Disabilities are going to be our Zoom czars, all right? They're going to be the technical backbone of this whole thing. We also have Jennifer Owens, who will be looking at monitoring the Q&A. If you have a question, put it into the Q&A. If any of our panelists are able to answer the question succinctly, they will do so in the Q&A. If not, Janet will track those questions and introduce them back when we go to the second hour, when we have our panelists actually tell us what they do and try to get into some larger issues. Our panelists are Paul Aronsohn, who is the New Jersey Ombudsman for Disabilities in New Jersey. Paul was recently, I'm sorry, you know what? I'm not going to get into all that because Paul will do a more detailed introduction when we get to the second hour. Bev Roberts from the ARC of New Jersey. Did I get that right, Bev? Okay. We also have Andie Iannuzzelli. Andie is one of the founders and is a board member of the RISN Center, which is a terrific project in Rowan, at Rowan University. And Allison Marcilla from Valley Hospital. So I think that's all the introductions we have. Hopefully when Phil gets on board, he can continue. All right. I am told by Phil by text that he will be joining us soon, but we'll give him time to do that. In the meantime, Kathy, Janet, and Sue, you guys are up first. I don't know what order I said before, but we're going to do this. Kathy, you can go first if we can promote her. And unmute yourself, Kathy.
Okay, good morning.
Hi.
I'm getting just a funny message. Okay, good. This was a great topic for me to talk to. I'm the parent of a almost 37-year-old adult son with CHARGE syndrome. And like many individuals with rare syndromes, Michael has very complicated medical needs, and there are many specialists. When Michael aged out of the pediatric system, one of the things that we lost was the team approach. Michael has an endocrinologist, a neurologist, a psychiatrist, a gastroenterologist. We're going to add a physiatrist because his motor skills are declining. And if I did not participate in every doctor's appointment, Michael lives in a group home, there would be no continuity between what all of these specialists do. And that is a real challenge for us. He has two endocrinologists because the issues are so rare. They're at Columbia Presbyterian. And none of the doctors really are out of the same medical center. They don't know what the other one's doing. And I am just very concerned about the lack of a team approach. I do have my daughter, who is an OT, phone in to most appointments because I'm getting older and there will come a time when she is responsible. And the final thing that I'll say is, along with the lack of coordinated care, Michael is not a verbal communicator. He is very significantly involved multiply. I find the doctors are very reticent to even examine him. They generally do a blood pressure, a height, and a weight, and they kind of approach him like, can we do that? I just feel sometimes he doesn't even need to be there. I have looked, I have reached out to the Morristown Center for Developmental Disabilities. They're not taking patients. I actually did do an intake with the RISN Center. But at the time when I did the intake, they weren't offering all the specialists that Michael really needs. And that's what I'm really looking for. So that's really what I wanted to bring up, that Michael is the sum of all of his needs. He is not an endocrine system, a gastro system. He really needs that team approach where the doctors talk to each other, and he needs a quarterback. So that was the issue that I really wanted to bring forward.
Thank you, Kathy. Okay, Sue Salic is next. Sue, I think we just raised your hand, so
yeah,
if we can just promote her.
I just have to join audio time.
Okay. Oh, I see you now. And after Sue, Janet, if you can just promote yourself. Okay.
Recording in progress.
Susan, you're muted.
Sue, you're muted.
No, it's not my fix. Janet, when you promote her, you have to, well, either you or Kireker have control of her speakers. You have to unmute her. Are you able to do that?
Unmute. Yep.
All right, Sue's going to sit down in my seat. In the meantime, we still have a technical issue because people's muting and unmuting button may not be working.
Okay, so my son is William Salic. He has autism, and we had an emergency room visit with him for a severe blood clot issue in his leg. We walked into the emergency room, it was the end of October. It was extremely crowded. I asked for assistance that he couldn't wait 6 hours to be seen, and I was completely dismissed. I begged. I said, I'm standing in a hospital, my son needs help, and nobody's going to help him. Not one person would even come over and even actually visually look at him. So we actually left with the fear that he was going to pass away overnight, to be honest. We took him to a cardiologist the next morning. He immediately had a vein scan done and was found that he had severe blood clots in his leg. The worst part of it was the dismissiveness from the people in the emergency room. To be honest, I was looking for help and was told I was not going to get any. I asked, was there any alternative? Could I sit in a quiet room someplace with him and wait for a doctor to see him? And I was dismissed time and time again. And as a parent standing there begging for help for your child, crying for help for your child, and being told there is none was horrifying. That's all I have to say. Thank you.
All right, thanks, Sue.
I'll go mute me and then I'll.
That's right. Janet, can you go next?
Yes.
Janet, are you
I'm
available?
here. I'm here. No, I'm here. Sorry. My name's
Oh, there
Janet
you are.
Tavares. A little over 3 years ago, I took my 11-year-old communication impaired, high support needs autistic son to a pediatric emergency room in Bergen County. After examining him, the attending doctor informed me that my son had an infection and needed to be treated with an intravenous antibiotic. He added that it would take about 15 minutes for the medication to drip. I explained that my son would not cooperate because of his severe sensory issues and requested that he be given an oral sedative before the IV was introduced. I also mentioned that the anti-anxiety medication Ativan had proven to be effective for him in the past. My request was met with defensiveness and an explanation on why the antibiotic needed to be given intravenously. I assured the doctor that I was not questioning or rejecting his treatment plan, but simply asking for my son to be given something to reduce his anxiety, since it would otherwise be extremely difficult, if not impossible, to get an IV in him. The doctor proceeded to interrogate me by racing through questions on when, why, where, and what IV treatments my son had previously received. I gave him everything he asked for and described in detail what he will not cooperate would look like. But it didn't matter, because next he told me he didn't have a sedative and couldn't get one, which I couldn't prove was untrue, but questioned since we were in a hospital. To appease me, he offered morphine, which also had to be given intravenously and was not going to prevent my son's fight or flight reflex from triggering. As predicted, when the nurse approached him with the needle, my son tried to leave the room and began screaming and crying. It took 6 adults to restrain him and insert the IV. Dad held him in a bear hug. I draped myself over his upper torso. A nurse draped herself over his legs. 2 nurses held each of his arms while another inserted the needle. We held him in that position for over 25 minutes. The scene was so loud and chaotic that a security guard stopped by the room. To add insult to injury, the doctor chose to wait for this wrestling match to inform us that he was admitting our son because he would need 3 more doses of the antibiotic over a 24-hour period. The nurses were tasked with figuring out a way to keep his hand stable and the cannula hidden while we panicked over how we would manage to keep him calm and distracted from the bandage and the cannula. When it was over, the doctor confessed to us that he had never witnessed anything like that before and that he had no previous experience treating an autistic patient. That being said, then why didn't he just take my word for it? The trauma we experienced could have been avoided. Healthcare providers need to trust and consider what caregivers of people with disabilities tell them and be willing to have an open and honest dialogue.
Thank you, Janet.
You're welcome.
That was very clear. Okay. We're also going to have a number of survey questions while we participate in this thing, in this town hall. So Kireker, if you wanted to pop up a survey question, that'd be great. Next up, we're going to have Phil, who's chaired Region 2, Ning Wang, and Nanati Kopstein. If you 3 could just raise your hand. Actually, Phil, you're already on the panel, so you don't have to do that. But if Ning Wang and Nanati Kopstein can raise their hands, so you can go to the top of the list, and it'll just make Janet's job easier to get you recognized.
Sure. You want me to be next, Bonnie?
Yeah.
Yep. So my story is my son has seizures along with his autism, and the last seizure that he had, he was taken to JFK hospital in Edison. We were having lunch actually, and then his seizures came. And so when we got to the hospital, the doctor there took a look at him, just made sure he's okay. After about 3 hours or so, 4, he said, okay, he's looking good, he could leave, but he wouldn't get up. it turns out later that he couldn't get up. And so I asked the facility and the doctor to have him stay overnight just to observe him. And they said, okay. And the next morning, he still could not get up. So I asked for a neurologist to evaluate him as well. And he agreed that there's something that's not quite right. But the other doctor, the first one that saw him, you know, he was ready to release him. He says, there's no issue that I see here. So, but since we have the neurologist agreeing with us, the hospital, you know, allowed us to stay. And that became a week, at least a week and a half before we found out, and only from, you know, from changing the bed sheets, we noticed that he winced in pain. And it turns out later on, because they were taking x-rays from his chest and above, it turns out he had 2 fractures in his back. And, you know, part of the reason, you know, he's not able to communicate very well. He's on the lower end of the spectrum. So it took a good, you know, week and a half to figure that out. And then, you know, just a week again to have him stay there and recover till he could stand up by himself and walk to a certain extent. And then he was another 2 weeks in the rehab just to make sure he's okay. So, you know, something that should be fairly easy and, you know, doesn't have to be dramatic and all that, you know, he's not being able to communicate, but the parents, us trying to tell them, you know, there's something wrong here. Fortunately, we saw, you know, both sides, with one doctor trying to do one thing and then the other doctor believing what we're trying to say and find out what was happening. And, you know, it turned out it was something very serious. So that's my story in this particular, for this presentation today.
Okay, thanks, Val. I'm just going to ask that, just to make this easier, if you've signed up to speak, please try to use the raise hand function so we can recognize you. In the meantime, the next group of speakers, Ning Wang. Ning, are you here?
Can you hear me?
Yes. Ning?
Yes.
Okay. We can't see you though.
Can you see me now?
Oh, yes. Okay.
Hi, everyone. I'm Ning Wang, and I have a 20-year-old son who's nonverbal and with very limited self-help skills. I have a question to share from insurance point of view. The qualified Medicare beneficiary is a great program, but billing for the QMBs is making things more complicated and discourages doctors to accept QMBs as patients. Is it possible for Medicare Advantage plans to issue insurance cards for QMBs that show correct copays, which is $0, so that doctors will not insist on copays and risk possible sanctions? Can Medicare Advantage plans bill Medicaid directly for the copays? Can Medicaid automatically pay doctors using billing information from Medicare in the same way as Medigap automatically pays doctors using billing information from Medicare? These are questions because doctors will be more likely to accept QMBs as patients because they won't have to bill Medicaid on top of either Medicare or Medicare Advantage. Thank you.
Thank you, Nanati. Okay, I think that Bev Roberts is going to be able to answer that question, but we'll wait till we get to the panel. The next person is Nanati. Nanati, are you with us?
Yes. Good morning. My name is Nancy Kopstein. I live in Mercer County. The primary physician of my daughter, Monica, was a doctor at Penn Medicine Princeton Health in Middlesex County. Everything was kind of good until March 2020, when Monica was 32 years old and needed a prescription, which required her doctor to contact Horizon NJ Health, her Medicaid MCO or Managed Care Organization. Monica has a private health insurance, Medicare, the traditional Medicare, and Medicaid. Her doctor's practice had information on Monica's 3 insurance plans. The doctor's office told me that because they did not take Medicaid, they could not electronically submit the certification to Horizon NJ Health of medical necessity for the prescription. The certification was required because Monica had to take the brand name, not generic, for medical reasons. Furthermore, I was told that Monica could not receive any future medical services from that practice because she had Medicaid. In other words, the practice refused to provide services to patients with Medicaid. To me, this refusal was blatant discriminatory against people with Medicaid, who tend to be low-income seniors or people with disabilities. I submitted a complaint to Disability Rights New Jersey right away. A lawyer there referred me to a 2013 newsletter of the MAHS, the Medicaid office, state Medicaid office, which stated that medical providers are prohibited to balance bill Medicaid beneficiaries. For these reasons, healthcare providers who want to receive full payments for services deliberately refuse to take on patients with Medicaid. Even before the incident, medical practices in Mercer County had refused to accept Monica as a new patient as soon as I told them that she had Medicaid. So it's common knowledge among those with Medicare or private insurance, not to mention that they had Medicaid when making appointments for new doctors. In the end, I had to find a new primary physician for Monica at the start of a pandemic. No wonder why New Jersey's Medicaid network of providers is inadequate compared to other states. Thank you.
Thank you very much. Okay, the next group. Oh, that was not it. Okay, the next group is going to be Radhika Dukapati, Helen Haviz, and Amy Lerner. Radhika, I think you have your hands up, so we should be able to find you pretty quickly. Can we promote Radhika? Or Radhika, can you say something so we can see you?
Hi, my name is Radhika. I have a son with disabilities who sees a lot of different specialities. I try to keep them in one place, but not always it is possible. We see a couple of specialties in Robert Wood in New Brunswick, but then they don't have like ophthalmologist, dentist that we see. So my son needed an ophthalmologist. I took an appointment. They said, yeah, they will see my son, and I take him there. Oh, I take him to that place. They say, oh, we cannot see your son because we don't see patients like your son. And then finally, I had to find another ophthalmologist. And then, you know, that he was kind enough to see my son. I face a lot of issues with insurance. One of the questions I posed today is my son has private insurance through his dad, and he has Medicaid. So sometimes the area we live in, there are not many doctors take Medicaid. So And then he has been seeing, I will talk about his GI doctor. He has been seeing GI doctor with both insurances. He moved into a private group. And then they basically gave us an appointment. We go to the place and check in. They see in the system my son has Medicaid. They don't want to check him in. But the doctor was kind enough to see him again. And so I don't know what the rule is. Some say, we cannot balance bill Medicaid patient family because private insurance is under family insurance. Because he is a Medicaid thing. And there is another provider who says, no, you can pay it. So what is the standard? I want an answer for that too. Access of care is very difficult for those with IDD with multiple issues. It's nice if we can get designated places or doctors that somewhere DDD puts up on the website that says, hey, these hospitals are for IDD and these are the doctors who will see IDD. And, issue is with psychiatrists too. They don't want to see everybody. So it will be nice to have a place for our loved ones to go to. Not only we families take them there, but also when we are not there, that they can continue to be taken there. That is all I want to say. Thanks.
Thank you very much. Okay, the next is, oh, by the way, there should be a poll button at the bottom of your screen. Those are some of the questions that, we'd like to get some information on. All right, thank you, Radhika. Now it's Helen Habiz. Helen, are you there?
I'm trying to mute. I'm trying to figure this out. Hi.
Okay.
Trying
if you
to
can put your camera on too, that'd be great. But if not, that's really up to you.
Where's the, okay, there it is. I was trying to find it. Hi, my name is Helen Hafez. I have a daughter who's severely, Angelman syndrome, severely mentally disabled. And the nightmare that I've been going through is my daughter has severe anxiety and I can't get help at all through her insurance. They made me use all the resources. You have to use every resource we have. I've called every single number. I've done everything they ask and they still can't help us. I can't, she does not let me have people in the house because her anxiety is so high. So I can't have people help me with her care. I can't have family come in with her downstairs or people come in to do repairs or anything because her anxiety is so high. A neurologist says, go to psychiatrist. Psychiatrist, only one I saw her ever was the ARC, and they said, she needs to go to neurology because she's severely mentally disabled. Her mentality is like 1.5. She can't speak. She, she cries all the time for everything, and she just wants her, her mother all the time, and that's it, and when she's in day program, she's fine because I'm not around, but she makes it very difficult. So I've asked the insurance, could she go to an Angelman's clinic, which is out of state? There's one in there's one in Boston, Massachusetts. They have a clinic in New York and PA, but there's not one in New Jersey. And every time they won't answer me after that. Usually she has a coordinator with Horizon, and usually the girl gets back to me when I have questions for anything. I need some numbers. She needs a specialist or something. But for this, nothing. I've been going through this for years. So I went to another neurologist thinking maybe they could help me. No, he was like, we only treat seizures. So and I've had a lot of the issues, although I hear all the other parents having too, on top of this, but this is like the toughest one because she makes it impossible for us to have any kind of, family, life or social life, but no, like some doctors will feel bad and they're like, oh, I'm trying to help you, but there's nothing, I can do, they'll give me other numbers. I've went through numbers that even the insurance hasn't given me, just trying to, get help, for her. So, it works out for all of us, but it's like to no avail. it's very difficult. And I understand a lot of the other things the other parents are going through because I've done it too. I mean, I've been going through all that too with not doctors not wanting to see her because she doesn't have, you know, the right insurance, or staying away from her. Like, you know, when he touch her, like every time I take her to see any doctor, there's never a table or nothing where they can examine her properly. You know, I mean, she just had a UTI last week, and we didn't know because she got dystonia so bad, and there was no way to get urine from her. I had to take her to the ER, and that was a difficult situation just to find out she did have a UTI, because like I said, she can't speak, and it took forever for the doctors to come in there, and a bunch of doctors to hold her down. And
Helen,
it was
I am so sorry for you. And I'm sorry to interrupt. We are at past 3 minutes now, but I do appreciate you being as open as you are. The next person is Amy Lerner.
Hi.
Hi, Amy.
Hi. Okay. It's really funny when this started, I said, I have only a short thing to say, but yet what all the other parents have said, I have to echo. There's a real issue with people like me who have both Medicare, Medicaid, and private insurance, and I can't figure out who submits what when, because they will submit it to Medicare, and then Medicare sends it to the private insurance, and the private insurance won't send it to Medicaid. So if somebody can come up with an answer for that, that would be great, because it's ridiculous to have 3 insurances and still have to pay something. But what my problem is that I feel like my daughter has been medically neglected since she became an adult. She's 40, and she has autism and very, very mild CP. But 6 years ago, we found out that she has a brand new genetic disorder that they're still trying to figure out exactly what it is. So no doctor is going to know about this disorder. When we went to pediatricians, they would find out everything. When you hit the adult situation, the doctors do very little to coordinate with other doctors. So I feel like she's got a bunch of specialists, and I work hard to find really good specialists. But the one area we still haven't found a solution to is dental. And I've spoken to Bev Roberts many times about this. And I guess the last time she really got a good cleaning was about 5 years ago, when Bev sent us to a doctor in Newark who she put her in, I believe, Beth Israel Hospital, and they put her under anesthesia for cleaning and x-rays. And the doctors did a good job, except they all left. And we were left in the recovery room with 7 hours of vomiting where nobody helped us. Nobody. And they finally discharged her, still projectile vomiting. And we had to deal with it. And it was like, that I won't ever do again. We still have not found a dentist. And I posted on Facebook pages, and people recommend people. And it's a lot of kids dentists who will take some adults, but whenever we contact them, they say they're not taking new adults. So it's just very, very upsetting to me. And I really do feel that if she has something really bad, nobody's going to find it, because I think they're afraid to deal with her. That's all I had to say.
Thank you for saying that so clearly. Okay, the next group we have is Jennifer Charles, Gina Marie, and Tina J. If you guys could use your hand raising function so that we can see you. Tina, I think I saw you on the here. I'm not sure if I can see you now, but if we can do that, Janet, if you can start with Jen Charles. Oh, we're still,
For some reason.
still have Amy. We still have Amy up, so it's okay. We love looking at you. But we need to take Amy down and put Jen up.
I don't see Jen Charles.
No,
Oh.
it's, I think my
really thought I
video
saw-
is not working.
Your video isn't working, but is that you speaking,
Yeah.
Jen Charles?
Are you able to enable my video?
Yeah. It's usually next to the mute button. It probably says start video right now, and you just need to press it so that the line is off of it.
No, it is, but it's not showing me.
Yeah,
my
Okay.
video.
you're not muted and your video isn't stopped, so you should be able to be
Oh,
displayed.
there she is.
Might be
Well,
something wrong on your
it's our
end.
screen.
Can maybe.
We can't see you, but I think I can hear you. I can hear her. Can everybody else hear her? All right. Well, why don't you just share your story? I mean, the video thing is unfortunate, but it's not going to stop you from sharing. Go ahead, Jen.
My name is Jen Charles. I live in Hudson County. I'm the parent of 2 adults with developmental disabilities. And my daughter, age 20, gave me permission to share this. On April 4th, 2022, my daughter visited her primary care doctor for the purpose of obtaining a medical clearance for an upcoming study abroad trip. My daughter has high functioning autism. One question on the medical clearance form simply asks if the student is currently under the care of any mental health professional or any care professional, including mental health, I should say, to ascertain there are no restrictions or precautions regarding travel. Upon reading that question, my daughter's physician asked her if she had any mental illness or mental problems, and if she was seeing a psychiatrist. My daughter reminded the doctor, as this was her second visit, as she had done before, that she does not have mental health conditions. She has autism. She sees a psychologist and now works with a life coach who is aware of her diagnoses and provides her support for time management and other life skills. Even a letter and phone numbers were provided by the coach in case the physician had any questions. But none of that mattered, because this doctor continued to insist and question my daughter on the fact that she was not seeing a psychiatrist for her mental illness and her mental problems. Seemingly, this was the doctor's interpretation of what the question on the form asked. By this time, my daughter was confused, frustrated, and mortified. She stepped out of the examination room, of which the door had remained open throughout her visit, called me at work in a trembling voice, and described everything that was happening. Not having any other immediate choice, I asked my daughter to go back and put me on the phone with the doctor immediately. In a tense and harried conversation, I attempted to explain to the doctor the notable difference between my daughter being on the spectrum, the autism spectrum disorder, versus a person who is diagnosed with a mental illness or a mental health disorder. It is not the same. Reluctantly and very harshly, the doctor agreed to complete the medical clearance form, but not without again repeating that she thought if my daughter was autistic, she should be seeing a psychiatrist for her mental problems. When my daughter finally left, she was nearly in tears and she was shaken. At best, that shocking experience demonstrated a lack of education and sensitivity from a professional who is entrusted with something so intimate and so personal as our health. At its worst, it showed that even a well-established medical professional is capable of grotesque ignorance, disinterest, and disrespect towards a vulnerable patient. Thank you.
Thank you, Jen. I appreciate you sharing that. The next person in this group, I think, was Glenda, but is Glenda on or? All right. Okay, I don't, Janet, can you see Glenda? No? All right, can we move on to Tina J? Don't see Tina. All right, you know what? Anybody who wants to speak, all right, if you could just raise your hand so
you have
you
Gina
can get-
Marie.
Oh, you do? Okay, good. Can we promote Tina?
No, I think you have me mixed up with another person that wants to speak.
Oh, sorry.
There's GJ and then there's me, but I'll go if she's not ready.
Whoever just spoke, that's Gina Marie?
Yes.
Go ahead.
Okay.
But I'd love to see your camera, your monitor.
Yeah,
but,
my
it's up to you.
I apologize. I not know. My computer tells me my camera not found, but I have
Okay.
one, so I not know
Alright.
what I do wrong.
That's fine. We can hear you.
Okay, I wanted to just go off of what the last person said. It's not just healthcare people, it's service providers too. Like I have social workers that tell, you know, like you have to go to one-on-one group. You have to go to psychiatrists. You need this, you need that. And the level of the dismiss and disrespect that comment alone says is very hurtful because they're a service provider. Where's their level of service in the scope of what their resource is supposed to do for them to step out of bounds to pass judgment on us when we're trying to, you know, live to the highest function level of our life? But I'm going to get to some other things because I can go well over my 3 minutes. Medicaids. I started off on Medicaids because I disables. I'm in Warren County now. I was in Middlesex when it first happened. I have brain injuries and I've gotten much worse. I got COVIDs, so I got even more new health issues since COVIDs. When I first started, I had Medicaids. On paper and supposedly legal, I'm supposed to have a social worker guru to help with all the wonkiness that a lot of the parents are telling you is there's gaps and it's just not working and we're all getting the scarecrow effect, but nobody gave us the cool beans, red ruby slippers. So now I am on Medicares. I'm asked for social worker help many times. I still get the same effects and responses. It's this person, that person, whatever. Who picks up the reins? I'm getting bills. I have Medicares. I have Medigap. There's some new law that I'm getting since COVID happened, where my billing bracket says 15 plus minute, 20 to 29 minutes, 45, 59 minutes. I've never been in the patient office for an hour. Maybe if you include x-rays and all other stuff, yes, but why are they billing per minutes? At what point my function levels is I allowed to get everything done in 15 minutes? If I go over that 15 minutes, it's now legal for them to charge me more. And with more than one insurers, I'm getting bills now. I'm confused. How is this legal? Where's the reasonable accommodates because we're disabled? We're fighting for the quality of our life at the best level we can. So I'm very confused and hurt. I've noticed a lot of people in network, they refuse to say anything about anybody else in the network, whether they're on the Pupikaka list, hurtful to us. I understand everybody has oops moments and doctors are human too. But when they tell me they not have time, they have other patients, they need to keep to schedules. And I'm told now I must bring someone with me. I'm 50. Maybe this is not right forum for me because I'm not a child, but all these people, they're advocates now. They're going to age out. Those advocates are going to go away. What's going to happen? Did I reach my 3 minutes? I don't know.
Yeah, you did. But Gina, I understand. And it does sound like you really do have enough. I mean, you really could speak for more than 3 minutes, but thank you for,
Yeah, it just
the
echoes. So
time
far,
consideration.
we've all been
Okay.
echoing, piggybacking off one another, and I
Yes,
appreciate you
I
having
do.
this.
Okay, thank you. The next person is Josie Weiss, has identified herself and raised her hand. And again, if anybody else wants to speak, please raise your hand. Go ahead, Josie. Josie? Oh, wait a minute. Josie just went off. All right. Okay,
I'm here now. Can you hear?
Yep.
Okay.
Can't see you though, but that's, whatever you want to do.
Technology, just give me a second.
I got that. I know that.
Technology for the aged. I empathize with everyone who has spoken to date so far. And my background is as a registered nurse, and I also am a special education teacher. And my son Matthew is an adult who has autism, and he's going to be 32 in July. So I have worked actually in medicine and in education. And I have to say I've had crises throughout. The system has changed. In 2012, he was diagnosed with catatonia, and it was a horrible experience to help with the state. Basically, the state had said at the time, I said, I'm in crisis, I need some help. And he said, you know how many calls I get of people on crisis? This was what the supervisor at DDD had said to me at the time. So it sounds like the system hasn't improved, although it's changed this model. But my concern that I want to speak about today is, and I had a horrible experience with my son in the hospital when he had pneumonia. If I weren't there to advocate for him, I think he would have been still in the hospital, possibly. He was admitted through the hospital, through the emergency room, and I've had good, positive experiences in the ER where they expedite him coming in. The care, however, it leaves much to be desired. I had to advocate, every day I advocated, I said, he was on an antibiotic. He needs to continue on the antibiotic because we entered with an antibiotic. They said, but he has the flu, and so we're going to give him an antiviral. Anyway, every day he was in the step-down ICU, and I said, are they going to start the antibiotic? And they said, well, the doctor will see, and the doctor will see, and the doctor will see. By the third day of antivirals, the nurses would come in and the doctor would come in and he'd say, well, he looks good. And I said, this is not good. He's sitting completely still. They're taking oral temperatures on him and he's a mouth breather. I said, this is so basically, I guess what I want to say is it wasn't even good medical care. So basic medical care was not great. And had I not been there to advocate, I finally insisted on him seeing, I said, I want to speak to the doctor now. And they sent up the infection control person and they said, oh, I understand somebody has a medical background. And I said, yes. And he brought me out to the nurse's station, looked at the labs and said, you see this number? He said, he has bacterial pneumonia. I said, great. And you've been treating him for 3 days, including ICU with antiviral as if he had viral pneumonia. So they did and then I had to ask for respiratory therapy and I had to ask for, which they gave me. So basically he was in for a day and a half and was discharged afebrile. His CAT scan had actually gotten worse during the hospitalization. So it was 5 days in the hospital, which should have been maybe 2 days in the hospital. But
Any
what I
closing comments, I've got 15 seconds left.
What I want to say is this is not a new problem. I actually had been interviewed on this issue when Matthew had graduated in 2011. Medicaid, he was also turned away by his eye doctor of 20 years because they saw he had Medicaid, even though it wasn't his primary. And they said, we can't take it because we saw that you had it. I said, but you don't bill it. I don't bill it. Can you see him? And they wouldn't see him. So I just want to hope that there's some time spent on what the solution is. So we send our kids from New Jersey out to Kennedy Krieger. We ship them out for residential programs of excellence. And I thought when we decided on these dedicated programs for excellence for each state, they were actually going to accomplish something, but it doesn't sound like they have. And I think the state needs to look at the amount of money that goes to hospitals compared to the proportional amount of people with disabilities and how they are addressing problems with people with disabilities based on the money and the population size. So there need to be people who can understand our kids, because we are eventually going to die. And if we don't advocate for this change sooner rather than later, nothing seems to be changing on that front. And that's my
Point made. Thank you very much, Josie. I think Yvonne Ellis is next.
I'm sorry, Dottie, who's next?
Yvonne Ellis, I think her hand is raised.
We have Eileen and Anna.
All right, well, you know what? Use your list, because I don't think my list is sorted the right way.
Okay.
So you do yours.
I think next is Eileen.
Okay.
Okay, I don't have a picture.
That's okay.
But you can hear me. Okay, so I'm trying to keep this short and to the point. My daughter is 32 years old. She lives in a group home. She's nonverbal. She's in a wheelchair. And she's been there 7 years. So fortunately, for the first 3 or 4 years, she was very healthy and fine. And when she arrived at the group home 7 years ago, it was still fee contract. You know, it was before we switched over to fee for service. And I guess because she's an EA tier, I thought she would have more care and better care. Anyhow, so what happened was, when she did get ill, she went to the hospital. The first time, somebody from the group home accompanied her. And when I arrived at the hospital, at least they were there, but they said they were leaving, that they do not leave any staff with her in the hospital. And that was news to me, because I had heard when she went into that group home 7 years ago that they did usually have a staff person go with them, especially when they're nonverbal, non-ambulatory, pretty much completely helpless. So I guess my point was, number one, they switched from contract to fee for service. And since they weren't getting paid because she was in the hospital, she was all alone in the hospital. So my husband and I, and finally somebody pointed out on like the 5th day in the hospital that I could get volunteers from the pediatric wing, which is like right across the hallway. And we did. So we got volunteers, because if you don't have someone with her, she'll crawl out of bed. She'll pull out the IV. She needs to have, you know, one-on-one in the hospital. All right, so that was my first point. It's just something I was kind of surprised about, that the group home said, no, we used to accompany them to the hospital, but now that we're not able to bill, we don't go. And then number two, the second time she went to the hospital, just a few months later, they did not accompany her. They sent her in the middle of the night, and I couldn't get there immediately. It was like 3 a.m., but I was able to get there about an hour later. I went into the emergency room, and there is my daughter in like what's called a straitjacket, tied to the bed and vomiting, which is the cyclical vomiting that she suffers from. And she was all by herself. And I'm like, okay, so that's just my two issues that I have, that I don't know if we will address them at some point down the road. But it's
Eileen, thank you. That's very, very clearly stated. Thank you, Eileen. Okay, I think we have time for 2 more, but we'll try to do them quick. Ann Backham and then Yvonne Ellis.
Hi, my name is Anna Beechin. I just wanted to let you know about my, I have an 18-year-old son. He's autistic, and I had a issue where I couldn't, I'm separated with my ex-husband, and because due to like domestic violence, and because he is the primary care holder on the insurance, when he comes home with me on the weekends, I cannot access Perform Care because of the fact that he's the primary care insurance person, and he doesn't want to access services during the week. And so on the weekends, I have lost all my supports. So I think that when people are separated for situations that are beyond, you know, not part of their control, they should be able to get help. And I wasn't sure like I said, I've tried a couple of ways. They've said my ex-husband is the barrier of care. However, my living situation is completely different. And I think that my son has suffered for that because he hasn't had services for like 2 years. And I haven't been able to keep him now because it's been difficult because he's severely autistic and nonverbal. And this is about to be costing me my guardianship now because I can't handle it. Unfortunately, I don't get the supports that I need. And I'm also a support coordinator. So it's frustrating that I help other people that I can't help my own son. So, I think that we do need to look at different systems and how it applies to different unique family situations. And that's basically what I want to say.
And thank you.
Thank you so much.
Okay, Yvonne, Ellis, and then we're going to turn it to the panel.
Hi, can you hear me now?
Yes.
Oh, okay, because you couldn't before. Hi, I'm not exactly sure what this, I know it has to do with medical. I just came across it like a week ago, but I'll just state my situation. I have a 34-year-old daughter that lives in a group home and she's on Medicaid. And it's hard to find good doctors that accept Medicaid, quality doctors. When I had her on my employee insurance, I did have quality doctors, but now it's hard to find them. I'm considering putting her on Medicare, but they'll take $170 out of her check every month. And I don't know how that works with the group home. I have to contact the group home to see how that works, if I can even do that. My daughter has fibroids and I had 10 pounds worth of fibroids that I got a partial hysterectomy for. And I don't want her to get where I was. So I have her eating healthy and I want her to have supplements. But through state law, you have to have a prescription for supplements. And a lot of doctors won't write prescriptions for supplements, but they'll write prescriptions for unnecessary medication. And I only give her medication if she absolutely needs it, not just because a doctor, wants to write her prescription. So that's an issue living in a group home. Like you have to have a prescription for everything, even supplements like vitamins and supplements. They can't give them anything without a prescription. And like I said, it's hard to find doctors to write prescriptions for supplements because we eat a lot of healthy and whole foods and organic foods. I try to get her to eat as healthy as possible because I don't want her health to end up like I was. So that's my concern with Medicaid finding quality. Yes.
Thank you very, very much for sharing that.
Thank you.
I think we're going to throw this to Phil, who is going to moderate the second part. I just want to say I love our panelists. I think they're terrific. They've met a few times and they really have a lot to share. All right, go ahead to you, Phil.
Thanks, Dottie. I sorry for coming in a little late this morning too. And I don't know, that was something, when I came in, I saw some introductions, Dottie, I think you, for the panelists, right? That was done or? No?
Yeah, they can, you know what, you should let them introduce themselves because they're terrific. They know more about themselves than we do.
All right, so let's start with Dr. Iannuzzelli, Andie, and you. So can you introduce yourself, I guess, just speak about, yourself a little bit, and then we'll go down the rest of the panel.
Sure. So hi, everyone. And thanks for your time. Thanks for sharing your vulnerabilities with us and your hearts. I think that's important. And hopefully we can have some solutions. Maybe not to everything, but at least some. So about me, as Phil mentioned, my name is Andie Iannuzzelli. I'm a physician and I'm down in South Jersey. I work at Rowan Integrated Special Needs Center, which is as the name depicts, we are a primary care practice that is associated with Rowan Osteopathic Medical School and down in South Jersey. And we actually provide an integrated care approach, disciplinary. We have social workers on staff. We have psychology, psychiatry, and primary care. Also, a little bit about me. I have a son who's 24 years old who has special needs. He's on the spectrum. He has Lennox-Gastaut syndrome, severe epilepsy, brain tumor a few years ago. So I, like you all, am also, even though I'm a physician, I'm also a special needs parent. So I feel your frustration in a lot of what you're expressing today. you know, with Rowan Integrated Special Needs Center, we focus on primary care. And again, as I mentioned, we have social workers there to help support and parents in the direction of resources. Like, for example, if someone needs dental care, that's been a recurring theme this morning. We have a list of dentists in the South Jersey area, because that's kind of a catchment area, that accept Medicaid, that see our patients. They're kind of like our go-to dental practices. We have a list of psychiatrists. We just lists of practitioners who will accept our clients' insurances and who communicate with us well. So even though we don't have specialists in our group, we don't have, you know, for example, an ophthalmologist that is a RISN center ophthalmologist. We don't have a cardiologist whose practice is at RISN center. We have physicians in our area that we refer to who will communicate with us, who have our cell numbers, who will call us at, you know, 9 o'clock at night to give us the results of our patients' testing. So we do have trusted physicians that we partner with in our area. We also, because we're affiliated with a medical school, we train medical students. We give them lectures about the special needs population, the IDD population. They come and work with us in the office, shadow us in the office. We also train residents, and we train internal medicine residents, but part of what they do is they're with us in the clinic for a day and a half each week. And so they see our patients, they develop an appreciation for coordination of care that's required for the special needs population. And they actually spend a couple of weeks during their first residency shadowing the psychiatrists, the psychologists, and the social workers. So they can see the symphony of care that is required in giving truly good care to our patient population. And they always love those 2 weeks because it really gives them a lot of insight into what it takes to provide care for our amazingly complex population. You know, so our hope is that in training medical students and kind of getting a hold of them, even in their first year, I have first year medics who shadow me on Thursdays, getting a hold of them in their very first year of medical school, that's going to start planting seed of appreciation for what it takes to take care, to give good care to patients. But then they hear lectures in their second year, they come in and work with us in the third and fourth years. And so the hope is that regardless of what specialty they end up going into after medical school, whether they go into anesthesiology, whether they go into OB-GYN, whether they go into orthopedic surgery, whatever they choose, they at least have an appreciation and an understanding for what it takes. And if they don't, if they ever have questions, they know they can always reach out to us, whether they end up in California or Florida or Minnesota, wherever they are, they can always call us if they have questions, and we can help guide them literally for the rest of their careers. So that's a little bit about me, a little bit about RISN Center, and you know, hopefully as we go through with the other panelists, we can talk about solutions to many of the concerns that were brought up by the parents and caregivers.
Thank you, Andie. Next, Allison, if you could introduce yourself and your background. Thank you.
My mouse didn't want to work to unmute myself. Okay, so my name is Allison Marcilla, and I'm the social worker here at Valley Hospital up in Bergen County. First, I want to just thank everybody for their stories. It's very emotional to hear, and I really appreciate your taking the time and energy it takes to retell that story that I'm sure you've told over and over again. We hope that it's not falling on deaf ears this time. So to introduce myself, I've been a social worker here for about 10 years. My more important job that everyone will relate to is I am Jessica's mom for 21 years. And I have been in many, many of those situations in hospitals and group homes and in all of the stories. She was in pediatric group homes as well. So I get it. That said, my colleagues and I are incredibly passionate about this problem, issue, the concerns that we all share for our loved ones. And I'm really excited to tell you that because we are so passionate about it and because we know this is a problem that has been going on, like Josie said, for many, many, many years, we are energized to get the word out to our administration, and it is working. We are in the process of developing a very strong program. I do not want to overpromise and underdeliver, so I will tell you we are in the creation phases, but we are really taking a lot of advancements to do this. We have the complete blessing and backing of our administration to make system-wide changes. And what this is going to look like is that our department can be sort of a patient navigator. We have put together training, like, Andie, you were saying, to train the staff is the most important thing, to support them on what they need. So we are putting together programs that in advance of the patient coming in the medical records, the needs, the special needs are already in there. So that whether your loved one is coming in to see, cardiology or GYN or wherever, it's already known so that we don't have to retell the same story over and over again. We don't have to say, for my daughter, when you approach her, please approach her this way. It will disarm her. She will not feel so afraid. When if your child likes the lights in the room dim, if your loved one cannot wait in a waiting room and you want that escort right from the parking lot, right to the room, we will set that up in advance for you. We understand that that's so important. We understand, the need to have a loved one or a volunteer or someone that gets it. Our child life specialist and our child life department with our volunteer department is really working to understand our needs. My colleagues and I are so involved and invested in making sure system-wide we are getting, again, team meetings across the board. We want your input. We want to know from you and from parents what will work. We understand the insurance issue. I'm going to leave that to Bev. That's her area of expertise. But where I think Valley is starting to really shine, and hopefully will continue to, is that system-wide our staff is being educated, system-wide our staff is being supported, and that we will take a very, very, very comprehensive, somebody at the beginning had mentioned, we need a quarterback, we need coordination of care, we need a team approach. Absolutely. And that is something that we hear and that we are really excited to really start implementing with everybody's support. So training and, it's all coming through. So please let us know, keep us posted on what your needs are. I think we know because we live it too. And we're excited to see what we can get done.
Okay. Thank you, Allison. The next panelist is Beverly. A little bit about yourself as well. Thank you.
Sure. Thanks very much. Hi, everybody. I also want to thank Dottie for pulling this together. This was, I think all of us have heard a lot over the years. I've been working for the ARC of New Jersey for 30 plus years, but to hear all of this information, one parent after the next, with some differences, but also a lot of the same kinds of problems, it was, I think, helpful for all of us to hear it, and even more so for the legislature, because I think that this information is going to be passed along to the legislature, and I'm very eager to have them hear this information, and then they can reach out to anybody for additional follow-up. But I think that's extremely important as well in terms of getting some changes. I'm thrilled to hear what Allison is starting over at Valley Hospital. That's great, and hopefully maybe that after it started there will be other hospitals that will decide to implement it as well, because that's very, very needed. I know what Andie has been doing over at RISN, and that's also wonderful. We also need more. It's wonderful to have something that works really, really well. Excellent. We need more of it for sure. So just a little bit about the areas that I can try to address, which has a lot to do with some of the insurance questions. So I direct a program at the ARC of New Jersey that's called Mainstreaming Medical Care, which, as I said, I've been doing for more than 30 years. And not necessarily my choice, but over time, it looks like I've developed expertise in insurance and Medicare, Medicaid, SSI, SSDI, Medicaid HMOs. Again, not necessarily my choice, but that's sort of what has evolved over time. So a couple of things that I wanted to say with regard to some of the parents' comments about that. The first is, and maybe this is something that the legislature could help to clarify, it is my understanding that when somebody has private health insurance and Medicaid, that there should not be a problem about their being seen at a doctor's office. Not to expect that Medicaid is going to pick up the copay, because they probably won't. But most of these families had the private insurance first, and then they paid whatever the copay is up front, whatever, 10, 15, 20, whatever it is. They would pay the copay, they would be seen. And then at a later point, their son or daughter also got Medicaid. And that's when the doctor's office was like, oh no, we don't take Medicaid. The parent isn't asking the doctor's office to take Medicaid. The parent is just saying, this is the same private insurance we've had for years and years. Accept the private insurance, the parent will pay whatever the copay is. I think maybe part of the confusion perhaps is there is a rule from CMS, that's the Centers for Medicare and Medicaid Services. That rule is when you have Medicare and Medicaid, that the doctor can't balance bill. So maybe some doctor's offices heard something about a rule, something with Medicaid, they really don't want to do maybe certain patients or take longer, more complicated. Who knows why exactly this misinformation is out there on the Medicaid and private insurance aspect. With Medicare and Medicaid, it is a problem. Because of this rule with CMS saying the doctor can't balance bill for a person who has Medicare and Medicaid. The doctors who want to get their 100% payment, when they see that a person has Medicaid, some of those doctors were like, oh no, we want our full payment. We don't want to violate CMS rules. We won't see you. I disagree with that vehemently. My disagreement, it doesn't matter at all. So I do know that there are some parents who don't mention Medicaid. They just go in with their Medicare, they pay that 20%. That's their choice to do that. There are also some doctors who do waive that extra 20%. And I don't have a list, but every once in a while, a parent will tell me, well, that doctor does just waive that 20% that they're not going to get for a person who has both Medicare and Medicaid. There's also something called dual eligible special needs plans, or DSNPs. If a parent enrolls their son or daughter voluntarily into a DSNP, absolutely voluntary, if enrolling in a DSNP, then everything is covered. No worry about this doctor won't take it, or copay or payment or whatever. So that's the good news, but there's a bad news part of DSNPs. The bad news part is the networks are not nearly what you could see if you just saw a Medicare doctor, because so many doctors take Medicare, way more than take any of the Medicaid managed care organizations. If enrolling voluntarily into a DSNP, you must stay within the DSNP network. That's all the providers you would need to see. That's also the medication formulary. You wouldn't have a separate Medicaid Part D drug plan. You would have to use the formulary within that DSNP. And if you are in a DSNP, again, it's voluntary, but if you're enrolled in a DSNP and then there's a particular doctor you want to see, you go outside of the DSNP and think, well, Medicare will still pay 80%. No, if you go outside the DSNP, you pay 100% of the doctor's bill, because you've given up essentially the original Medicare to say you want to be in this particular managed care network. So it's like a good news, bad news. It really is an individualized decision based on your son or daughter and what their needs are and the doctors that they need to see. But from what I've heard from so many of the families today with a son or daughter with really complicated needs, You can certainly check out who the providers are in a DSNP, but I am very concerned that you might not find the providers that you're really looking for in a DSNP. So again, we can talk more about this later, but I just wanted to answer those questions that I know were raised that were insurance related. Thank you.
Thank you, Beverly. Next one is Paul. Not to be the last, but I just wanted to let the ladies first. So go ahead, Paul. Introduce yourself.
Thanks so much. And good morning, everybody. It's so great to be here and have this opportunity. First of all, again, like Beverly, I want to thank the organizers for putting this together because it's such a great idea, and I hope we can do more of these listening sessions. And you know, also want to join my colleagues in thanking all of the parents who spoke today and gave their personal stories and shared with us. No, it's not easy. As someone said, you know, I'm sure you've told the story multiple times, and it's just difficult and painful and frustrating. So we appreciate this opportunity immensely. My name is Paul Aronsohn. I am New Jersey's Ombudsman for individuals with intellectual or developmental disabilities and their families. And as some of you know, because I've had an opportunity to meet with and work with some of you, it's an office that's relatively new in state government. It was created a little over 4 years ago by the state legislature. It was signed into law by Governor Christie in January 2018, and I was appointed by Governor Murphy in April of 2018. So actually today is my 4-year anniversary. Actually, it was April 16th. And I had the opportunity, actually, one of the first families I worked with was Allison's, and it was actually before I actually started. It was the weekend before I started. So our office was created because it was a recognition in the legislature that while there are a lot of resources in New Jersey for children as well as adults with intellectual and developmental disabilities, there's also a lot of folks falling through the cracks in the system. And there's a lot of gaps, and it's a very complex system. It can be overwhelming for families. And so our job really is to, first and foremost, is to serve as a resource for individuals and families of all ages across the entire state. And we just really try to help connect people with the experts on today's panel, Andie, Allison, and Bev, and, you know, as well as other, you know, folks in government, out of government. We really try to sort of serve as a nexus, if you will, between sort of the folks making decisions and those affected by the decisions. So we spend most of our days troubleshooting. As some of you know, we get emails, phone calls. We, to the extent possible, meet with you in person at your homes. I've been in more Starbucks and Panera Breads and diners in the state, in fact, we do it that way rather than have people come to our office in Trenton, because not only does it make it easier for families, but it really gives us a perspective that a lot of our colleagues don't have the opportunity to get by sitting in your homes, by meeting your family members. You know, we really get to see, feel, and sort of hear up close, you know, some of the challenges you're facing. And it helps us not only to help you in your particular situation, but it helps us more generally to help other families too, because we really get a really personal and in-depth sort of understanding of the challenges. So we work on a day-to-day basis, 5 days, often 7 days, you know, really just trying to troubleshoot and help folks sort of on particular issues. But we also work with individuals and families to try to find ways to fix things that are broken in the system. Again, we have that opportunity. We serve in a unique position in that we're very grassroots and working very closely one-on-one with families like yourselves. But we also have access and work very closely with, you know, the Assistant Commissioner of DDD and the Assistant Commissioner of Children's System of Care and folks in the Governor's office and, you know, folks in the Attorney General's office, working a lot with public safety and in our community. So we have that ability to sort of connect people and sort of to help raise issues in a way that that may not have existed fully in the past. And related to that, what we try to do in our office is to make sure that your voice, the voice of individuals and families, is heard in a very meaningful way. And sometimes that's just relaying what you tell us with our colleagues, but sometimes it's also connecting you and trying to help facilitate meetings. We do that often with families and decision makers because we think it's so important that they hear unfiltered, through us, exactly what you're facing. So, I would say for those of you who haven't contacted our office, please do so. We'll give you the contact information. There are some families, it's just a one-off deal. We help them, connect them, and move on. But with other families, it's been an ongoing relationship over a few years. There's 3 of us in our office, myself, Christine Bachter, who's our deputy director, and our newest hire, we grew to 3 people a couple of weeks ago, Charles Dodge. All 3 of us have a very personal sort of lived experience with disability, all different also, which helps us not only to connect with families and individuals, but it helps us to understand. And again, we have sort of different areas of expertise. So I would definitely encourage anyone who has an issue, if it doesn't get resolved today, you've got 3 excellent experts on the panel. But beyond that, feel free to reach out to us anytime in any way. We'll try to help you. Today, I'm here mostly as I often am in a listening mode. And again, I just really appreciate this opportunity and thank everybody for coming and participating.
Thank you, Paul. So I think, let me just mention, I'm listening to what everybody's saying and the parents and what they've provided. 3 things are standing out to me. And before, I think we're going to open it up to the folks here, right, Dottie and Kyoko, to ask their questions, right?
Sure, whatever you want to do, Phil.
Okay, so basically, it seems to me that the first issue is access, and Beverly made mention about some physicians not accepting Medicaid, and we'll go back to that. And I think there's a question that's posed on the chat too. The second is billing. Where we have one family member who has all 3 Medicare, private, Medicaid, are still getting billed, and then some who are and then there are people, they're still getting multiple bills from multiple different providers that they have to go through. So somewhere in that world of the service, and I think this is just in general as a nation anyway, we have that issue with insurance. And then the third is care. And Andie and Allison made mention about what they're doing in their areas, one in the north, one in the south. But I think we probably need something from the state and probably as a nation as well, to get this thing resolved, to get, the service, but, just to get the right care for our population. So maybe I'll start it off. There was a question from Susan Salic about, Medigap. Medigap, if they do regular Medicare, Medicaid to pay for 20%. I'll open that up and then we'll see how the things goes with the rest of the folks in attendance.
All right, so I have some bad news about Medigap for our folks, and possibly, I know that Paul Aronsohn has recently been appointed to the President's Committee. So I don't know if there's any chance that you could do anything with this issue. I'll explain what it is. We have tried to advocate for a change. Apparently this problem on Medigap is at a federal level, because I've talked to people at the state and they basically said this is federal. And this is it in a nutshell. And it's very unfair. And I'm just the messenger about this. If I could change it myself, believe me, I would. This is the rule. If a person has Medicare first and then gets Medicaid, they could purchase a Medigap policy when they just had the Medicare and then keep it when Medicaid started. Yay for them. The problem is our folks almost always have Medicaid first and then Medicare starts later. And there is a federal regulation that if you had Medicaid first and then Medicare started, that you cannot purchase a Medigap policy. Our feeling is it should be voluntary. It's not going to force anybody to do what they don't want to do. But if it were voluntary, then you could have it purchased, but you cannot. And perhaps this thinking was developed because of the thought that somebody who had Medicaid first, then had Medicare, was very, very low income, and maybe they didn't want them to be pressured by insurance companies to pay for a Medigap policy that they couldn't afford. I understand that. But for our families where you have individuals with really complicated medical problems and where they certainly could afford a Medigap policy, we think it should be permitted. And the other thing is maybe the thinking was, well, by making it a requirement that you cannot balance bill a person who has Medicare and Medicaid, that would take care of it. Can't balance bill. But then the doctors say, well, we do want our 100%, and we don't want to violate the rules on balance billing, and we just won't see your son or daughter. And that's the way some doctors have gotten around it, because you cannot force a doctor to treat a patient. You can say you can't balance bill, but you can't force them to treat a patient. And I have heard from a number of families who have been distraught because they had had a good doctor for their son or daughter in the past. And then once the Medicare, Medicaid started and the doctor's office knew about it, they were like, well, no, sorry, I'm not going to treat your son or daughter anymore. So this Medigap is definitely a problem, something that we in the state have not been able to resolve.
Thank you, Beverly. So another question, I'm just looking at the chat and the Q&A is,
Yeah,
go ahead, Dottie.
I'm sorry, I think that Jen Owens was looking at that too. So maybe Jen can help you weed through the Q&A.
Okay. Jennifer, are you seeing any other questions there that's outstanding that we can address from the panel?
There is one, I don't know who can answer it. It says, can a parent's employer provide insurance for a loved one under the CCP or when they have Medicaid? It would save the government money. I'm not sure who can answer that question.
Can you say that question one more time, Jen?
Yeah, I didn't understand the question.
It says, can a parent's employer provide insurance for a loved one under the CCP when they have Medicaid? I'm not sure what CCP is.
Community care program.
Yes, when they have Medicaid.
So the one thing that it's not exactly answering the question, but I just want to be sure that parents know, and I think a lot of them may, but just in case there's somebody who doesn't, if a parent has private insurance from an employer, so every son or daughter, no matter with a disability or without, is covered up until the age of 26 on the parent's health insurance plan from the employer. And then at 26, if there is no disability, you're done and you can COBRA or whatever, but you're finished with your parents' health insurance. For our folks who have a disability that is such that, for the most part, they're not going to be capable of self-sustaining employment. That's really the issue. They certainly can work, and a lot of our folks do work, but the salary that they receive is not going to be self-sustaining. So these folks can stay on the parents' private health insurance beyond age 26, and it's just a matter of the parents going to HR, getting a form. Usually it's a pretty easy process. Getting the form before the 26th birthday, the parent fills in some, take it to the physician fills it in, certifies that this individual has a disability, is not capable of self-sustaining employment, allowing the individual to stay on the parent's health insurance beyond age 26. I don't know that that's actually answering the question, because if somebody has already gone off of their parents' private health insurance, I don't know. I mean, you could always ask the employer about having them get back on after 26. For the most part, I think employers are happy if they just don't have to cover them anymore, but they will do it if it's an ongoing, continuous type of insurance. But I don't know if they would put the person back on if they already were off from being 26.
Yeah, Bev, it's Dottie. I just, I guess the part that I didn't understand was CCP and whether if you have the community care program type of waiver, if that had anything to do with insurance, because that was part of the question.
Yeah, so again, I'm not sure, but I think part of it is, first of all, you could be on the CCP and still be living with your parents, or you could be on the CCP in a group home. So part of that could be, are the parents paying for more than half or more of that person's living expenses? If they're living at home, then the answer is yes. If they're living in a group home, then the answer may be no, that they're not paying. It's probably Social Security money from the state. So it would probably have to be looked at on an individual basis, but there's probably a good possibility that if they're in a group home, that the parent is not paying for 50% or more of their living expenses.
Okay. Jennifer, out of the question from the chat.
No, I don't see any other questions that's directed at the panel. Perhaps you could open it up in the chat.
So,
May
go
I
ahead,
say
Allison.
something? May I say something, Fel? So what I think needs to happen. Well, not what I think. What does need to happen? And the question is, how do we make this happen? It would be great from point if we had a RISN center in every county where there was a medical center of excellence that was dedicated to the IDD population, where we had staff who knew how to interact from the front desk, from the scheduling people, social workers, nurses, medical assistants, physicians, where it could be a primary care home for not only our kids with IDD, but also for the caregivers. And that's what we do at RISN. We take care of the caregivers as well, where we also have psychologists and psychiatrists on staff. So there's this interdisciplinary staff that is adept and well-trained at dealing with the population. It'd be so amazing if we could have one in every county. So there was like this well-known go-to center for every county. And then if we could have regional hospitals. I don't know that it's realistic to have also a hospital in every county. I don't know that we would need a hospital in every county that was a center of excellence for inpatient treatment of the IDD population. But at least if we could identify a hospital or system in the north part of the state, the central part of the state, and the southern part of the state, where kind of like what Valley is doing, we could train the staff at one dedicated hospital for each region that could accommodate our kids. And so that's what Valley's doing. I'm working in South Jersey to do a similar type of program where we don't know if we're going to be doing it with Cooper Hospital, Jefferson, Virtua, or Inspira. Those are kind of the big hospital systems in our area. It's most likely going to be Virtua, where, when one of my caregivers calls and says, I'm having problems with my child and I think they need hospital level care, I can send them to the ER. Right now, what I do is if I'm sending someone to the hospital, I call the ER, speak with the ER doc, let them know that one of our patients coming in, let them know about the nuances of care. And so at least they have a heads up. Someone's going to be arriving to their ER that has some type of special need that needs to get in right away, that can't sit in the waiting room, can't tolerate that, and kind of get fast tracked. So right now we're just calling all the hospital where our patients are going to let them know they're coming. But it would be amazing if we had these regional centers that were patient centers of excellence, and then have county centers that were the outpatient centers of excellence. That's my vision. That's my dream. I may be calling you so I can tap your brain about how we start a program down in the South Jersey region like you've started up at Valley.
Yeah, I think there's one more question. I'm sorry. I don't want the questions unanswered. I think this one is from...
One second. I'm going to put you on hold for a second because Allison, I think, was going to respond to Andie. And then
I'm sorry.
That's okay.
Go ahead, Allison.
And answer a question that I had seen in the group chat. Andie, yeah, absolutely. I feel like we're going to try to kind of bridge this gap, and we'll share ideas and things like that. The two things that have come up in our years of trying to pull this together, COVID slowed us down a bit. Number one is training, for sure, training all the staff, training, make it system wide. But the other thing that's come up, and I think this is super important, is that everyone says, no, it's great, I understand it, but they still don't know who to call when that person is coming in, right? Or what we've been hearing is we need a point person. The staff is so happy that we are coming in and we're saying, we'll take it, we'll help you, we'll, be the bridge, but they want to know who to call. So like we have set up an email, and like one email that everyone knows, they see us, this patient is flagged that they have a special need, go, and then that comes to us. And for Andie, whether, you know, at RISN, whether it's, you know, the team, the social worker, the whoever is going to be that point person to then pull it together. That's what our staff is asking for. Like, they think it's all a great idea, but when that person comes into the emergency room, or that patient's admitted, or that person has an appointment for an X-ray or an MRI, we understand that this person has a special need, but what do we do? Who do we call? And we want someone to kind of own that. That's what we've been hearing. So just sharing that with you. And of course, my colleagues and I, you know, we want to own it. So, so that's that. The other question I did see in the chat, that I put a yes in there, but I want to speak more specifically, was yes, I physically work for the Center for Child Development, where we're pediatrics. We have a lot of subspecialties here for pediatrics. We go up to age 21, but absolutely this program is for continuity of care for within the adult system. We are not as, we don't have as much resources right now because this passion has started through the Center for Child Development, but yes, absolutely open to adults. We don't want to turn away anyone who's going on the adult side as outpatient or in the hospital as inpatient. We've connected with the inpatient adult social workers too, to make sure that they know to contact us. So yes, for adults as well. Thank you.
Thank you, Allison. Go ahead, Jennifer.
Okay, there's a question here. I think it probably goes to Beverly. It says, if Medigap can be purchased, is it correct only Medigap F and G would pay the Part B excess charge, but only Medigap D is available for people over 65? I'm not sure.
Under 60. So, okay. So the issue of Medigap broadly is that it's primarily for people 65 and over who get Medicare. Now, for a lot of our folks, they're way under 65 and they're eligible for Medicare, and they're eligible for it, by the way, in case anyone doesn't know exactly how that happens, because they've had Social Security Disability Insurance, SSDI, for 2 years. That's the trigger. So I think somebody had said, one of the moms had said she wants to see about getting Medicare for her son or daughter. It's not something that you can just say, I would like to have it, I'm going to get it. It has to be SSDI, Social Security Disability Insurance, for 2 years. And the way to get that is typically it's because of mom or dad's work record, that mom or dad either started to collect their own Social Security retirement, or mom or dad became disabled or passed away. Those would be the trigger to start SSDI for the son or daughter with IDD. And then in 2 years, they get Medicare. And that happens automatically. It's interesting. It's not something that you then apply for. It's something that comes after 2 years of SSDI. Sometimes parents were like, well, why is this happening? I never applied for it. You also, if you have Medicaid first and then you get Medicare, you're not going to pay, even though there's going to be a form letter that's going to say Medicare Part B is like $170 a month. The reality is when you have had Medicaid first and then Medicare, you're not going to have to pay that $170 a month. Medicaid will pick up that cost. Now, sometimes it can take a couple of months of having that Medicare, and then the computer systems communicate with each other, and then that $170 a month is picked up automatically. So that shouldn't be a reason for a parent to say, well, I don't want Medicare Part B because of the cost, because you're not going to have to pay that cost, even though people don't really know that. And so then the question, I just want to make sure now that I went off on a tangent, about the Medigap. So with regard to Medigap for people under age 65, and again, most of our folks can't get it because they have Medicaid first. But if it was something that could be changed at the federal level and would allow Medigap for our folks, what that means is there is only one Medigap policy available for people under the age of 65. So typically that would be somebody because of a disability and the SSDI for 2 years, and that's why they have Medicare. And so if they're able to purchase a Medigap policy, there is just, it's not like you have a choice of A, B, C, D, whatever. it's only one type, and I believe it's Horizon that has that policy. So it's not even checking with different companies. Under age 65, Horizon does sell a Medigap policy. And I know there was another question in the chat about what is balance billing. So balance billing means, so for a person that has Medicare and Medicaid, so Medicare is going to pick up 80% of the bill. 20% is not covered by Medicare. If or when the doctor then sends a bill for that 20% that Medicare didn't cover, that's considered balance billing, or billing for the balance that was not previously covered.
Okay, thanks, Beverly. Go ahead, Jennifer. Next question.
Okay, there's one here that's been sitting here for quite some time. It basically says that some providers outright rejects Medicaid patients, and some providers are okay to see Medicaid patients. And they want, the person's asking, what is the correct approach? Because the doctor is saying some of them has to do with balanced patient billing, and others are saying that it doesn't. So the person wants to know, what is the correct approach?
So this probably goes back to a comment that I had made earlier, and I'm assuming that there's not a Medicare involvement, because if there's a Medicare involvement, I had talked about that with CMS, and you're not allowed to balance bill, but then the doctor can say, I don't want to see you. If it's an issue with private health insurance and Medicaid, which we hear about, with private health insurance and Medicaid, there should not be a problem. However, a lot of doctors' offices think there is a problem. And if they think there's a problem, my saying there shouldn't be a problem may not change their minds. Well, it won't change their minds. So I think maybe it needs to, in some way, come from maybe the director of Medicaid from the Medicaid office, and with some encouragement perhaps from the legislature to issue something in writing that would be clear, again, not from somebody like me who's an advocate, but somebody at a high level that could basically put something in writing to say, if you have private health insurance and Medicaid, that there's no reason why the doctor's office shouldn't accept it and then just bill for whatever, like they would if you didn't have Medicaid. That's my thinking. We'll see where that goes. And one more comment that I just wanted to make, actually, when we were talking about RISN and Valley and how great that is, I also wanted to be sure people know that the Developmental Disabilities Center in Morristown, so there's Morristown Medical Center and there's also Union Hospital, they do have a specialty program. They unfortunately cut back their hours at their Morristown campus, but it is a specialty program that was developed a number of years ago to treat individuals with intellectual and developmental disabilities, including autism. I just wanted to be sure people knew that.
Okay, there's another question here. I think it's for you, Beverly. It says, if an employer is willing to provide insurance to an individual in a group home where the parent does not contribute 50%, why is that not allowed?
So I have a fact sheet that I put together on that, and my go-to person, which people need to know if they're doing insurance issues, who to go to check with issues. There's somebody at DOBI, the Department of Banking and Insurance, that has given me that information about the 50%, in terms of is the parent paying 50% or more. So that's my answer to the question. That was information that I received from DOBI.
Okay, there's another one here. It says, my daughter gets SSI. Can she get Medicaid? She's 34.
If somebody gets SSI, they should be receiving Medicaid. If it's SSI, and there's also sometimes confusion about SSI and SSDI, a lot of confusion. But when a person gets SSI, which is supplemental security income, Medicaid comes automatically.
I think the question was Medicare.
The Medicare?
Medicare.
Oh, it's Medicare.
Medicare.
Okay. Okay, so if somebody is, Okay, if that would make more sense, that would be a question. If somebody is getting SSI, they're going to get Medicaid. The only way for them to get Medicare is after 2 years of SSDI, supplemental security income.
Bev, do you mind explaining when they switch over to SSDI from SSI?
Sure. It's when a parent, it's usually that a parent becomes, decides whether they're 65 or not, that the parent collects Social Security retirement, which a parent could collect as young as 62. If they're doing that, there's a reduction over what they would have gotten if they waited longer. But a parent could decide to take retirement income from Social Security as young as age 62, or they could wait as old as 70, or any time in between. So the the parent collecting their Social Security retirement income, or if a parent becomes disabled and collects Social Security because the parent has a disability, or a parent passes away. Any of those three things will trigger SSDI, Social Security Disability Insurance, for the son or daughter with IDD, and after 2 years, they get Medicare automatically. There is also another way, it doesn't happen as often, but the other way is that the person themselves, the person with a disability, is employed for a significant number of quarters on their own employment. And then they can get SSDI from their own work record, and then 2 years later, Medicare.
Thank you, Beverly. Jennifer, next question. You're muted. Okay.
This one, it says, it's for Bev. It says, can you explain Part D Medicare? They spelled it incorrectly. It says Part D Medicare. I think that's what they mean. Low income benefits or co-payments allowed with this type of coverage. I think it's Medicare.
So I'm not sure that I understand the question, but if a person has Medicare and Medicaid, there are different parts. And we have fact sheets actually at my office that we've put together, and it's on my website. So if anybody wants fact sheets on Medicare and dual eligibles, which is people who have Medicare and Medicaid, I'd be happy to send out those fact sheets. But so very briefly, Medicare has parts A, B, D. D is the drug benefit. So if somebody had Medicaid first, so the change for people, which can be a little jolting, is if you have Medicaid and you don't have any private insurance, and you have medications that are on the formulary of the managed care organization, there's no copay for those medications. With Medicaid, as long as it's on formulary, no copay. When you switch to Medicare and you have Medicare Part D, the drug benefit, there is a small copay for all of the medications. I'm not sure if that's what was being asked, but there is a small copay unless if you're on the CCP. So if you're on DDD services, either you have supports or you're on the CCP. If you're on the CCP, there should not be any copay, or MLTSS, but that's managed long-term services and supports, probably doesn't pertain to anybody listening to this. So the CCP part of it is that you should not be paying any medication copay within Medicare Part D if you're on the CCP.
Thank you. There's one question that has been here since 10/20. It says, what is a qualified Medicare beneficiary? I think this is for Beverly.
So I think what they're referring to is a person who's dually eligible for both Medicare and Medicaid. That's my understanding of how the term is used, that they have both coverages, is my understanding.
So I just want to, just for a sec, so just for the folks, just to let you all know, this is being recorded. So and there's a lot of questions going back and forth. So after this will be, you can view this at your leisure when this is all over. And it's a lot of good information for some folks. So, you know, don't worry about it. it's being recorded and everybody will know, or catch up later on. Go ahead, Jennifer.
Okay, this person says, is there any advantage for one parent to start collecting SSI while the other parent has employee insurance? It's several parts of this question. Would the child with IDD then go on Medicare, or should they wait to get Medicare until the parents with insurance retires?
No, this is an individual decision. So if that family wants to contact me and I can think about the specifics of their situation. I don't want to give a general answer that might not meet what a specific family needs. My email address is broberts@arcnj.org, and I would be happy to get additional information on this. I also, and I know that's not the purpose of this town hall, is not to talk about some of these really in the weeds issues with Medicare and Medicaid, but I have slide presentations that I've put together both on people who have Medicare and Medicaid and all those issues, and also the issues about when a parent is planning to retire and what will happen with SSI and SSDI. So I know there's a bunch of questions that have come in here and there, but I do have slides that are available and that I've done presentations, and I certainly would be happy to do additional presentations, Dottie, if you want me to, if somebody wants me to schedule something specifically on these topics, I would be glad to do it.
Oh, Bev, that's going to happen.
All right, go ahead, Jennifer.
1 second. I think that's it. I don't see any new questions.
Well, so I see one, and I'll pose it here. It's from Kathleen Freeman. Why is care including administering of medications, including controlled substances, given in group homes by individuals who are not certified by the Board of Nursing, as they are in other facilities? The panel acknowledges the complex medical needs of our loved ones living in group homes, so this seems discriminatory. So I don't know if anybody in the panel would want to.
So yeah, I can address that. So, I come from a background, before I came to RISN Center, I worked in internal medicine, critical care. I was a kidney specialist, and I was also then medical director of dialysis units, as well as of assisted living communities, long-term care communities, memory support units. And in all of those settings, no one administers medications unless they have certification to do so. They need to be a certified medication administrator, which is like a certified nursing assistant who has extra training. They need to be an LPN. You need to have a certification in all of those other settings to administer any type of medication. Group homes, for whatever reason, are the exception. It's my opinion that our kids are complex. This is a really complex group that sometimes is on many different medications that are administered multiple times per day. You've got behaviors and first that they need to deal with. In my opinion, there should be a certification process required of people who administer medications in group homes as well. In my opinion, group homes essentially are assisted living communities, just with a different demographic, whereas assisted living typically is more of a geriatric population. Groups are more of a special needs or IDD population. So I feel like it's similar settings, just two different demographics. And I do feel that there should be certification in group homes like there is, in these other situations. And I think someone actually brought up, I'm looking at my notes because I took notes on everyone who spoke. Someone who spoke earlier today did have a child who was at a group home, and there also was a concern about the home staff not accompanying their client to the hospital. They kind of put them in an ambulance and sent them out, or maybe dropped them off at the hospital, but then didn't stay with them through the hospital. We need to have policies whereby there is an accommodation made so that people with intellectual and developmental disabilities have someone with them at all times while they're in an inpatient setting. You know, with my son, I know no way that we can leave him alone. As soon as we would walk out of the room, the IV would come out, the leads would come off. And so I do think that moving forward, and that's where we have an opportunity to work with hospitals as well in this, in creating these regional centers of excellence from a hospital standpoint, an inpatient standpoint, whereby there need to be ones from a hospital standpoint as well that are educated in how to take care of our patients in case the group home can't accommodate. So I think there are a lot of opportunities for us to do work at the level of group homes as well in improving care, whether it's medicating our patients or their clients, whether it's accompanying them to the hospital, whether it's working with behaviors, etc.
Just one little comment on what Andie just said is there is not enough money and funding for group homes. I think that's at the base. I don't know that there's any group home that wouldn't want to have staff that are as qualified as possible. We all want that. The funding is not sufficient, and the hiring of DSPs it's extremely difficult when a DSP can make more money working at Walmart than they can, then people leave because they have a tremendous amount of responsibility. They have their own bills to pay. They can make more at Target or Walmart. And so the recruitment and the retention of staff for group home work, which is extremely complicated, and there's a high level of work that they need to do, there just isn't enough money. So I would love to see an increase that would cover what we would like to see for staffing, which right now is not sufficient.
Thank you. Thank you for the panelists. We're coming close to the noon time. Thank you to parents as well, and for those who spoke about and shared your experiences. Hopefully, we've started a conversation into thinking about getting and improving the care that's provided, the billing issues that's been mentioned, and also the access, which are the three main things to me that I got from this presentation today. Like I said, this is all recorded, and Kyoko will be making it available to the folks who attended this meeting. You will see an email, and thank you again. Dottie, anything you want to say?
Only that I just saw Paul posted his email. Use it. He's a good resource. Right? Actually, everybody on the panel has just been fantastic. Thank you for your input and your view of what we should be moving toward.
Okay. Thank you, everybody. Have a good Easter weekend. Bye-bye.
And